So we have a double presentation, as you can tell from the title. One's on the lung and one's on the liver. And our title for this is Too Little for the Lung is Too Much for the Liver. So we'll start with the lung, and then I'll finish with the liver. I want to remind you that next Thursday, there is no grand rounds because it's Thanksgiving, and I even put on my Thanksgiving tie. So my partner in this is Helen D Couto, who I'm going to introduce now in just a minute. So we're going to start off with this for our outline: pathophysiology of alpha-1 deficiency, and it is a deficiency for her, lung disease, how to treat this, and then I'll finish up with how to get the liver more healthy. It's not really a deficiency, as I hope to convince you, but an excess of something that's not needed. She has no disclosures, and I am on the data safety monitoring board for a bunch of companies, none of which are on alpha-1, but are on hemophilia or acute porphyria. And with that, I'm going to introduce Helen to come up and start with our lung aspect. Thank you.
All right, thank you all. I'm Helen. I'm in the Pulmonary and Critical Care Division, and I'm honored to be joining Dr. Luxon today to talk to you all about this unique disease that affects both of our organs, but differently so. And I want to start with a case of a gentleman who came to see me in clinic a few months ago, who actually came to see me for asthma, and he had a new diagnosis of bladder cancer. His asthma was a mild intermittent asthma that was well controlled in ICS-LABA for many years. And he reported stable dyspnea on exertion for about the past decade or so with intermittent abdominal bloating. He had a newly diagnosed bladder cancer, and the workup of that was found to have some abnormal LFTs, for which he got subsequent imaging, which showed cirrhosis and some varices. His social history was notable for kind of a mild tobacco use disorder in his teens and 20s. He worked as a lawyer. He didn't have any other sort of occupational hobby-like exposures or travel. And his family history was only notable for kind of an unknown autoimmune platelet disorder. So in working up his cirrhosis, he got abdominal imaging, which showed some interesting findings at the bottom of the lung bases caught on that scan. And I'm going to break my rule of doing systemically going through the imaging, but what we can see best here on this coronal view is there's a basilar predominant paraseptal and centrilobular emphysema with sort of a lower, a lower prevalence of emphysema at the apices. And so what does this atypical distribution of emphysema clue you into? This kind of red flag board question statement, which would be alpha-1 antitrypsin. So in working him up for his new cirrhosis, he had a negative infectious workup, he had negative autoimmune serologies, but he had a low alpha-1 antitrypsin level of 21, which is lower than the sort of the protective threshold, if you will, of about 80 milligrams per deciliter. And so we diagnosed him with alpha-1 antitrypsin deficiency that was likely the cause of both his basilar predominant emphysema as well as the new cirrhosis that he was incidentally diagnosed with. So I want to go through a couple of things. One, what is alpha-1 antitrypsin, and talk a little bit about how it works as a protein itself, how its deficiency causes lung disease, and ultimately how we manage that. But what I hope you really take away from this is a little bit of appreciation just for how neat this little protein is and what it's taught us about science, and some humility as to how much havoc a single amino acid point mutation can wreak. So starting with what alpha-1 antitrypsin is, I want to talk a little bit about the scientific history of its discovery, because it's a pretty cool story about scientific collaboration, evidence-based medicine, and how chance favors the prepared mind. And so our story starts in Malmo, Sweden, with a doctor by the name of Dr. Laurel and a household name you might recognize, Dr. Waldenstrom. And these guys were really excited about this new lab technique that they were working with called protein gel electrophoresis. And they were using it to characterize a whole bunch of different proteins, ones that you will recognize, including they worked on transferrin, the structure of ceruloplasmin, and haptoglobin. And because they were so excited about gel electrophoresis, they started screening all the patients they were seeing in Malmo, Sweden with this gel electrophoresis. And they noted something interesting. They first found 2 patients from their respiratory ward who were missing the alpha-1 band on their gels. And they said, well, that's probably not coincidence. And they kept an eye out for this. And they found 6 more patients from the respiratory ward missing this, 4 of whom, interestingly, had young onset emphysema, which they thought was strange. And they later worked with a series of collaborators to figure out that this missing alpha-1 band was the protein alpha-1 antitrypsin. And so they worked with a a lot of different collaborators, including several awesome female physician scientists from back in the day, including Dr. Diane Cox, who's pictured here, who then kind of worked on further characterizing alpha-1 antitrypsin and figuring out its structure as well as how it caused disease. And they noted on their gels that there were a lot of different variants. And Dr. Luxon's going to talk more about these genetic variants later. But Dr. Cox figured out that it wasn't actually a glycosylation problem as indicated here, which they initially thought, but a problem of a bunch of different point mutations. And so the next thing they had to figure out was how alpha-1 antitrypsin actually worked normally and what it bound and how it caused disease. And so Dr. Jessica Lewis, she's a hematologist in Pittsburgh who had a patient with actually a severe bleeding disorder, interestingly enough. And she found that her patient with this bleeding disorder actually had a mutant alpha-1 antitrypsin. And she compared that patient's alpha-1 antitrypsin to antithrombin and found that it had a similar point mutation of methionine to arginine that actually changed the binding of alpha-1 antitrypsin from protease to thrombin and was causing thrombin inhibition. And this is actually how they discovered the reactive center of alpha-1 antitrypsin and figured out how specific the amino acid was to dictating the binding of this protein. And so not only did they characterize alpha-1 antitrypsin through this roundabout way of a patient with severe hemorrhage, but this sort of unlocked the concept of this class of proteins called serpins, serpin protease inhibitors, which really led to our understanding of serpin protease versus antiprotease balance in terms of causing disease, as well as conformational disease from aggregation of these proteins, which Dr. Luxon will talk more about, that we see in other disease states like neuroserpins. So how does alpha-1 antitrypsin actually work? It's pretty cool. It's a suicide protein that works akin to a mousetrap. So it has this high energy state sort of reactive arm, which has a single amino acid side chain binding to its target protease. And when the protease binds this arm, it unleashes that high energy stored unstable state, causing the arm to actually swing with the protease bound to it around, effectively body slamming the protease into the alpha-1 itself and destroying the protease and itself in that process. And because it destroys itself in that process, which is why you need a constant supply of alpha-1 antitrypsin to create this protease antiprotease balance. And why is that balance important? What happens if we let neutrophil? So just to be clear, the protease we're talking about in lung disease is neutrophil elastase. And so why is it bad to let neutrophil elastase reign free? Increased neutrophil elastase activity is essentially going to lead to increased innate immune activity within the lung by two sort of primary mechanisms. The first is cleavage of the CXR receptor, which leads to decreased neutrophil phagocytosis, and then also decreased lipopolysaccharide responsiveness leads to decreased bacterial killing. It also unleashes a whole host of other innate immune cytokines, including receptor binding, which increases IL-8 and neutrophil chemotaxis to the lungs, increased mucus production from goblet cell hyperplasia, and then direct destruction of the extracellular matrix through increase in matrix metalloproteinases, leading to tissue, all of this leading ultimately to tissue destruction and the emphysema that we see clinically. So I want to briefly talk just a little bit about the epidemiology of alpha-1, given that it is such a rare disease. There's two main methods to studying its kind of prevalence and incidence, which is one, looking at genetic allelic surveys. And these sort of alleles, broad population sampling surveys for alleles kind of estimate anywhere between 100,000 of the PiZZ mutation and about 1 million of the PiSZ mutation. But what's interesting is there's a significant decrease of actual clinical phenotype that we see. The largest screening study was actually a newborn study done in Sweden, which only found about 1 out of 1,600 newborns with mutant alleles. And then there was a study in St. Louis that actually looked at blood donors and found only out of 700 blood donors that they found with the alleles, only 28 had clinical disease. And as you can see in this table, only about 1 to 2% of clinical cases actually occur out of the expected cases based on population allelic frequency. And this is probably for two reasons: decreased phenotype penetrance, which I'll talk about in a little bit, as well as, of course, likely under recognition and under diagnosis of this disease. My patient made it all the way to age 65 before he was diagnosed. So I do want to talk then a little bit about why we have this variation in phenotypic penetrance. And part of the hypothesis behind this is that alpha-1 we know is we're classically taught that it's synthesized in the liver, but it's actually also produced in lung and gut epithelial cells, as well as in macrophages. And this presence of mutant alpha-1 antitrypsin in the lung causes problems in and of itself too. So of course, we talked about unopposed proteolysis from the deficiency, but the mutant protein itself causes increased alveolar cell death, as well as an interaction with smoking that further propagates and worsens the disease through oxidation of the alpha-1 antitrypsin. So as you can see in this cohort, the patients who were smokers had significantly lower elastase inhibitory activity compared to the non-smoking cohort and had a reduced enzyme inhibitory concentration compared to the non-smokers. And that's because the cigarette smoke actually oxidizes the methionine residue on that yellow swinging arm that I showed you guys earlier, which reduces its binding to its target protease. And then the polymerized alpha-1 protein in the lung itself also causes, in addition to, we talked about IL-8 as a neutrophil chemoattractant, the polymerized protein itself acts as a neutrophil chemoattractant, further worsening that pro-inflammatory state in the lungs. And this may explain why we see such a variation in clinical phenotype with patients who have the mutant allele. So this whole understanding of alpha-1 structure, how it works, and then ultimately how it causes diseases really led to an understanding of the concept of SERPIN protease inhibitors or SERPINopathies and conformational disease related to this unstable beta sheet through kind of a dual competing mechanism, one being a loss of function of the protein, as well as a gain of toxic function on the other end. Some other proteins that are within this class and that cause disease, and that understanding of alpha-1 sort of led to further understanding of like antithrombin 3, causing increased thrombosis. There's actually a temperature-sensitive mutation of alpha thrombin 3 that causes febrile episodic thrombosis, which I think is pretty cool. C1 inhibitor mutations causing increased angioedema, as well as antiplasmin mutations causing fibrinolytic hemorrhage. And of course, we have our Z mutation of alpha-1 antithrombin, which causes instability in this beta sheet. And Dr. Luxon's going to go more into detail about that, but that also led to an understanding of these conformational diseases due to protein mutants that aggregate, neuroserpins being the parallel structure. We know about a lot of neuro disorders now because of understanding of this structural aggregation of mutant proteins like amyloid and Alzheimer's, Huntington's, frontotemporal dementia. So I want to talk then a little bit about the clinical manifestations. We know it causes emphysema, we know it causes cirrhosis, but it's actually a little bit broader than just that. So within the lungs, so within newborns themselves, they just have a failure to thrive phenotype with alpha-1 deficiency. Within the lungs, there's actually a breadth of lung disease. So there's asthma, which my patient, I guess, was clinically diagnosed with, bronchitis, bronchiectasis, frequent pneumonias. Some other interesting manifestations include vasculitis, which is a rare manifestation, as well as paniculitis as a response to wound or trauma. So within the lung, we are sort of classically taught that it's a basilar predominant disease, but about 30% of patients actually have an apical disease. And there's some difference in physiology and presentation between apical versus basilar predominant disease, or it's at least hypothesized there may be. This is a little bit of a strange graph, but it's looking at the physiologic discordance or a DLCO versus obstruction. It's thought that basilar predominant disease may have worse obstruction due to reduced tethering of their surrounding tissue, and that apical disease has worse diffusion due to the inability to augment perfusion to the already well-perfused zone 3 lung. There is a higher prevalence, of course, of radiographic emphysema compared to actual clinical emphysema. Talked a little bit about why that might be. So patients with apical emphysema really should still be tested for alpha-1 antitrypsin, and it should be part of your workup for a new COPD diagnosis. Some risk factors for disease progression are not at all surprising, but smoking, of course, will worsen the clinical phenotype. As you can see here, current smokers have a much higher rate of FEV1 decline compared to never or former smokers. Other environmental and occupational exposures, including gas, inhalational, inorganic particulates, fumes, indoor air pollution, all of the things that we know cause lung disease worsen alpha-1 antitrypsin, not surprisingly. In terms of mortality, the mortality does come more so from severe lung disease than cirrhosis typically, and this is usually stratified based on the degree of obstruction. Again, not at all surprising that patients with worse obstruction tend to have a significantly worse mortality. Patients with mild obstruction actually tend to do pretty well if managed well from a COPD perspective and risk mitigation perspective. So how do we manage alpha-1 lung disease? The first is just good COPD care, smoking cessation, preventative care, bronchodilator therapy, supplemental oxygen. There was a study that looked at the role of lung volume reduction surgery, and basically this dotted line is the alpha-1 deficient patients, mortality in alpha-1 deficient patients after lung volume reduction surgery versus replete patients, and there really wasn't a mortality benefit, so unlikely to be a role there. But the main kind of interesting feature, if you will, of management that's different, of course, is the replacement therapy of alpha-1. There's two kind of main parameters that you could really think about the efficacy of augmentation therapy. The first is biochemical efficacy. Does replacement therapy actually adequately raise the serum levels and keep them there? Does the infused alpha-1 antitrypsin work like it should? And then there's clinical efficacy. Does it reduce lung function decline? Does it improve patient-centered outcomes in terms of functional capacity? And ultimately, is there a mortality benefit? And then the hard reality is it a cost-effective therapy? So starting with the biochemical efficacy, these were all studies that were done in the 80s and 90s. And this first study looked at a weekly infusion of 60 milligrams per kilo of alpha-1. And what they were looking at is, was this weekly infusion dosing schedule able to keep the serum levels above the necessary threshold? And they found that they were with this weekly. So this threshold is set at that 80 milligrams per deciliter I mentioned earlier. They also looked at whether the actual BAL levels were adequate. So correlating the BAL effective threshold to the serum effective threshold. And they found that after a couple of months of therapy that they were able to get BAL levels of alpha-1 high enough above this estimated protective threshold. What's interesting, though, is if you look at the controls, there is quite a wide range of BAL levels in the normal controls. And then also looking at the actual elastase efficacy of the BAL alpha-1 antitrypsin after infusion did show that infusion was able to increase the elastase capacity above an estimated threshold as well. Again, looking at a wide range of elastase activity in the normal controls. The weekly infusion schedule that we typically use of 60 milligrams per kilo is actually not based on a lot of data, which is, again, not at all surprising in medicine. But this particular study looked at the sustained serum levels after a single infusion at increasing doses. So starting at 30 milligrams, and going up to 250 milligrams per kilo. So this second line here is actually the 60 milligram per kilo dose that's most commonly used. And as you can see, the serum level actually drops below the protective threshold before 1 week, which is interesting to note. They also looked at monthly infusions of 250 milligrams per kilo and found that with that high dose of a monthly infusion, the serum level still dropped below the protective threshold before the end of the month. And so you can see that after each of these infusions, you see a drop in serum concentration. And so that's largely where the weekly infusion schedule comes from. So looking at clinical efficacy, there's not a lot of great randomized control or clinical data. The biggest study is this large clinical cohort registry retrospective study that looked at retrospectively at mortality. And what they found was that there may be a mortality benefit when you stratify patients based on the degree of obstruction. So this first graph is looking at the patients with FEV1 less than 50%, and these bottom two lines show that there is a mortality difference that is then lost when you look at patients with a higher FEV1. The other thing to look at is just how augmentation therapy affects the rate of change of FEV1. And what they found was that in patients who had sort of a moderate obstructive range between 30 to 60%, as you can see, this dotted line is augmentation therapy, and there's a slower rate of decline in those patients in that FEV1 range than in the control sample. But that benefit from augmentation therapy is lost in the very low FEV1 range and is also lost and actually reversed in a very high FEV1 range. The kind of more recent, the only randomized controlled data on augmentation therapy actually used an interesting outcome. So they looked at something called PD15, which is basically a CT measurement of tissue lung density. And so what they were looking at, so what PD15 is the Hounsfield's units at which 15% of the lung voxels or lung volume, if you will, is below. So emphysema has a really low Hounsfield unit on CT, like -900. So if more of the lung is destroyed and emphysematous, your PD15 will be lower. So they looked at a randomized a trial of 60 milligrams of weekly infusion and found that in the augmentation group, there was a lower rate of decline in lung tissue density as measured by this PD-15. There was, however, no difference in actual clinical outcomes like exacerbation frequency, symptom burden, actual FEV1, or diffusion. Both of these trials and the authors of these augmentation trials argue, though, that PD-15 might be a better marker of tissue destruction in alpha-1 deficiency than FEV1 because they postulate it's a more homogeneous disease than just smoking-related COPD, but that really hasn't been proven in other kind of studies or realms. And then there's a more recent 2015 trial. It's a larger multinational trial that also looked at alpha-1 infusion, same dosing schedule, and also looked at PD-15. There was two interesting findings from this trial. The first was that the rate of lung density decline was actually correlated with the actual post-infusion serum measurement. So if you remember that old study I showed you where the normal control had a really wide range of alpha-1 levels, even in normal control patients, this suggests that a single and dose and week schedule of infusion doesn't necessarily mean a predictive serum level outcome, and this one-size-fit-all treatment option may not be the best way to go. And we may need to do actually more targeted infusions, tracking post-infusion serum levels. The other thing that they had was they had a blind component of the trial and then to an open label extension in which, as you can see, the placebo patients in the blue dotted line after receiving augmentation therapy had a change in slope, a lower slope of their lung density tissue decline, suggesting that augmentation therapy, while there's no clear clinical efficacy, may still affect the rate of change of tissue destruction. So ultimately, augmentation therapy probably has evidence behind it biochemically. It makes sense, but there's really a lack of robust clinical data for it. It suggests that there's a decrease in lung function destruction and tissue destruction, lung function decline and tissue destruction, and that benefit may best be seen in patients in sort of the moderate obstruction range. And then unfortunately, and also not unsurprisingly, is that it's certainly not a cost-effective therapy. The last thing I just want to briefly mention is lung transplant, which has been studied in alpha-1 deficiency patients. And ultimately, there's a trend towards increased early post-transplant mortality and more GI complications, but ultimately no significant long-term differences. So probably still worth referring these patients for transplant if warranted. So bringing it back to our gentleman who initially came to see me for asthma and ultimately was diagnosed with alpha-1 antitrypsin, is that he had moderate obstruction and sort of a group B gold symptom burden for which he was started on a LABA/LAMA inhaler and is doing well on. The patient actually elected to defer augmentation therapy in part because he was feeling relatively well and he had a busy schedule that he felt could not accommodate a weekly infusion. From a cirrhosis standpoint, he's continuing to be monitored by our transplant team. Unfortunately, for now, is uncomplicated from that perspective. So with that, I'm going to turn it over to Dr. Luxon to talk about the liver side of alpha-1 deficiency.
We'll be back with questions in a minute.
All the questions go to him.
So I'm kind of frustrated that we call it deficiency, but what gets the liver is an excess of something that the liver doesn't want. So I'm going to tell you what's supposed to happen in the liver, what goes wrong in the liver, why does this lead to liver disease, and how to eventually fix it. You've heard what happens in the lung. We make the alpha protein, alpha-1 antitrypsin, and we squirt it into the bloodstream and everything's good, but that doesn't help the liver much. So I'm going to give a different perspective on when this started because it was really a liver disease, not a lung disease, as Helen mentioned, okay? So this is from the same article, interesting, I think, back in 1960, and this is a quote from this guy, Sharp. He became interested in liver disease as he should while an intern. So those of you out here in your residency, granted he's a pediatrician, but he's from the Midwest, so it was okay. And I put this other quote in him because back then in the 60s, we only knew really about 3 or 4 liver diseases. We knew about when the bile ducts didn't form. We knew about hepatitis A and hepatitis B, and Wilson's disease is the copper malabsorption. But then they found this, and they did these trypsin levels, antitrypsin levels in the serum, And they found out that there are a bunch of things that go wrong, as you can see by the yellow, really low levels. And then in the red, those were the parents. So they started to figure out that it was probably a genetic disease, because you can see the parents are a little bit low as well. Naturally, you got to have some old time EMs. So these are liver pictures for those of you who don't memorize liver EMs. And those big globs that I put the big red arrows on are the accumulated misformed protein that sits in the poor liver cell and screws it up. So you can see the globs that are there. Now here's a color picture. Anybody remember what it's supposed to be? You stain it, and then you try to wipe out the stain. If it's resistant, it forms these little globs that you can see, either reddish or purplish on this one. You can see those, I hope. So what happens is the malformed protein never gets out of the liver. You already heard what happens if it doesn't get into the lung, but now it's stuck in the liver. And so that causes a problem. So you heard from Helen about this gene. There are a whole bunch of variants, but what's supposed to happen on the right side is we make this the liver makes this protein. It's nicely made, it's squirted out into the blood, and everything else is good. But in this disease, it's malformed. It's not able to be squirted. So it sits there in the liver and knocks off the liver cells. Now remember, as a hepatologist, how do we designate viral hepatitis? We go A, B, C, E maybe. Well, these guys weren't any better. I saw Joe's here. Good. Excellent. I have a question for you in just a second. So you heard about electrophoresis. Have any of you ever done electrophoresis? This side, yeah. Thank you, Joe. Appreciate it. So we labeled, the liver docs, they watched this gel run. So you put proteins on a gel, put a little charge on it, and they move along. And so again, liver docs aren't too smart. So they called one M. They had another one Z, where they finally figured out what was substituted, another one S. So the normal is an M. Here's some pictures of it. This is Joe's question in just a minute. So you can identify how they migrate. Some go fast, some go slow. So we call this a Western blot. Here's the question for you. Because it was pioneered by a guy named Joe Western. It's a reference to Ed Southern. You have to turn the gel just perfectly so it's in the north or east direction. And somebody had already claimed northern. Anybody know? Joe will, of course. Mike, do you know in the back? Well, Ed Southern had already done this gel electrophoresis, but not for proteins. He'd done it for DNA. So some smart postdoc said, well, Southern's already taken, named after the guy who discovered it. So they said, we'll just pick another direction. They chose Western. So Western protein blots, which you saw from Helen, and you'll see from me, are nothing more than how to separate proteins. So how do you diagnose liver disease? Pretty simple. As in Helen's patient, you rule out other causes of chronic liver disease. You measure the alpha-1 in the serum. It's a deficiency in the blood. You can determine the phenotype of the protein, M, Z, etc. And you might want to do a liver biopsy, but I put a red arrow through that because we don't need to do that anymore. You used to. I showed you some pictures from those guys at St. Louis who discovered all this stuff, but don't need to. So the different phenotypes are ZZ is the bad one. And then there's another protein that's not quite as badly misformed, S, and then M is normal. You can see if you're homozygous, ZZ, you got bad disease. The serum AAT is very low, 10 to 45 this disease. It's disease causing. And then as you maybe add a few more good molecules or less bad ones, you can see things get a little bit better. But look at the risk for cirrhosis, pretty significant in the ZZ, the really bad one. But the transaminases that you see really don't help much. Your case was somewhat unusual. They were both elevated, but a lot of times they're pretty normal or not so bad, okay? But you measure the protein. Did that. So what happens? Why is this so bad for the poor liver cell? Well, some of it gets excreted. That's great. But most of it sits there in the ER. It can't quite get out. It's misfolded. It then gets together. They have kind of a party of misformed people. Sounds like the misfit toys in Rudolph the Red-Nosed Reindeer. They all get together and they form this big polymer. And that polymer is what's responsible for those globs that I showed you. And they sit there and the liver cell doesn't like it. They try to get rid of it. They activate a bunch of enzymes, the redox changes, and the poor liver cell, as shown here on the left, crumps. If you do that enough times, you get liver cell death. And finally, you get fibrosis, liver cancer, and liver death. So now you know what's wrong. How do you want to do to correct it? For Helen's group, we squirt in every once in a while the needed enzyme. Our problem's different in the liver. There are a bunch of these bad globs sitting in almost every liver cell. So what are the strategies? I put 4 down here for you. You can try to get rid of the bad protein, get it to be degraded so it doesn't hurt the liver. You can try to protect little sections of the cell, in this case, the endoplasmic reticulum, from this bad glob of protein. You can tell the cell, well, quit making the bad protein, make a good protein. That's what I usually talk on. Or you can just say, stop making the bad protein. So all of these have been tried, and I have a couple of quick examples to show you. One works quite well. So the first was trying to get the bad protein out before it turned into goo. So this is using chaperones. So you try to hook up this bad protein to something else that is excreted. The thing that's been used in rat models of this disease is a compound called phenylbutyrate. It's been used before. It increases ER folding capacity, kind of stabilizes the ER, and helps punt out bad proteins. But in humans, when we've tried this, there's no extra protein that comes out into the blood, and the liver doesn't get any better. They've also shown, and I've done some, I put in 2 clinical trials in humans again, and again, the ZZ, the worst phenotype to have, just didn't help. This didn't work. This was an abstract in the liver meeting now almost 9 years ago, never been published. So great idea, didn't work. Well, so you can't ship it out of the cell. How about if you just help the cell metabolize it a little bit better? So autophagy. 2 drugs that have been tried in a mouse model of this are rapamycin and carbamazine. And so then it worked there. Believe it or not, mice are different than humans. And so then they tried it in 20 patients, again, with this bad phenotype, the ZZ phenotype, but guess what? It didn't seem to work. But interestingly, it's because they didn't have enough patients that were willing to have a bunch of liver biopsies. So, that's how we judge fibrosis. And again, we want to see these pink globules on there. So we treated these patients with those medicines. This one was carbamazepine, biopsied them along the process, and we didn't really see any improvement in the liver biopsies. So the increased destruction didn't work. Trying to transport it out didn't work. Well, how about just telling the silly liver to do a better job? Well, again, animal experiments have been done to try to transfect the hepatocytes with the corrected gene. But this is a problem because there's so many variants. I don't think you mentioned this in your slides, but there are like 170 different variants of bad genes that cause alpha-1 antitrypsin deficiency, in my case, accumulation. And the transfection vector that we used often also causes some liver toxicity. So that hasn't really worked very well. So for the audience, what's the best way to correct the gene? You can do it gene by gene. Dr. Welton has the answer. You stuff in a new liver. And again, that is curative, okay? But kind of a little aggressive, I think. So you discouraged? Most of us were. We didn't have a treatment for this. We knew exactly what was wrong. We could pinpoint every genetic defect. We knew what was wrong. We could even help maybe a little bit on the liver. We couldn't do squat for on the lung. I misspoke. Couldn't do squat for the liver. Well, it was easy. All you had to do is get a Nobel Prize, and the rest followed. So let me show you how that works. These two guys in 2006, Craig Mello and Andrew Fire, discovered the secret of what's called RNA interference gene silencing. And I'll show you a bunch of cartoons about that. The idea is you put in a small piece of RNA that's designed specifically to block the bad RNA. My words of bad, okay? So Nobel Prize 2006. So here comes the cartoons. So on the left is what's supposed to happen without this interaction. So you can see the DNA makes RNA, mRNA comes out, the ribosome then back into the cytoplasm. Everything works well, it's good stuff, and the right protein is made. That's what normally happens for all of us. Where this interfering RNA, or SI, small interfering RNA works, is when the mRNA comes out, we hook onto it and we stop it. I'll show you some more cartoons. And so the protein never gets made. Now, they didn't do that in humans or interns. They used worms. And so again, here's some cartoons of that. We've worked this all out. This is what the Nobel Prize was given for. So this is double-stranded at the top here, double-stranded RNA. It goes down to a group, a protein complex called dicer. You'll probably see that on occasion. And dicer then cleaves the double-stranded RNA into smaller fragments. These other fragments now hook onto RISC, and one of those is blocked as it hooks onto the mRNA that you've targeted. So as next to the bottom, the target mRNA is broken down, it doesn't exist, and it can't make the bad protein. So a very few steps of a way to make a very small segment of RNA target the bad mRNA that you want to get rid of in a worm. So that's the theory. Does it work? Well, I start, of course, with mice. So we have mice that have this gene in them. And what this is does it knock down the mRNA of making the ZZ, the bad protein? So on the far left, as the control is just saline, and then they added different doses and treatment times. You can see the amount of RNA, the bad RNA, if you will, gets less and less and less. So yeah, great. That's at least knocking down the mRNA in a mouse. Well, next. So you start to put this into a human, and you have to do a lot of science to make sure that the little chunk that you put in of silencing RNA only hits the targets that you want. And I found this picture and I thought that really helped me, because some of the things we've done in hemophilia treatment, we get off-target effects. So if you look on the left there, you can see that the off-target lines up a long ways away, a long ways along the that target. So if you put a little another molecule in, now look to the right side. See that little orange thing called GNA? See how they stuck that in there? And now suddenly there's a little bend, isn't there? So it doesn't hook up to these off targets as much. So if you're into trying to figure that out, you get very smart guys to put into their small interfering RNA little molecule, little sections that bend it so it doesn't interfere except where you want it to interfere. And that's really high-tech science as we go forward. So a lot of science. Now, does it work? It does. I told you I'd show you at least one thing that really worked. This is from the New England Journal 2022. These on the graph shows you liver biopsied quantities in humans of the ZZ, the bad target. So you can see they start off at the left at 61. A little bit of variety, but after the treatment, you can see it goes down, and the mean goes down a lot, from 61 to 9. So it really gets rid of the bad protein in a human liver that has the bad protein to start with. So pretty impressive there. This is the name of the drug that's not commercial, it's being developed. Again, this is looking at serum concentration. The FDA is kind of wiggling a little bit about how to prove that it works. Not everybody wants to have a liver biopsy and quantitate the ZZ in the liver. So they're hoping that you can just measure it in the serum. Remember, some of it does get out. So this is, again, from that New England Journal paper just a couple of years ago, looking at the serum concentration of the bad stuff. So you can see it starts off at, let's say, 300 there on the far left. You can see the injections. Look at the trial visit time. It's a whole year. So when Helen showed you, she was injecting or giving doses of the corrected alpha-1 antitrypsin fairly often. These are monthly or sometimes bi-monthly. You can see the injection pattern at the top. But look what happens to the serum concentration of the bad stuff as a surrogate marker for getting it out of the liver. Drops down remarkably from maybe 300 down to about 50. So it really works. It's injected once or twice a quarter and seems to work. So for my section, I'm going to finish with the take-home points, not about lungs, because I don't know about those, but about livers. So remember, it's one of the most common genetic defects in the liver. Not the most common, but it affects both lung and liver. If you happen to have double copies of the bad gene, the ZZ protein, you have a 20-time higher risk of getting cirrhosis, and along with that comes the risk of liver cancer. Currently, the only therapy to get rid of that is to slip in a new liver. And you heard Helen's story about that person who probably wasn't going to get that done. But we have now new therapies based on genetic work where we put in a small interfering RNA that gets rid of the bad protein by getting rid of its subsequent mRNA. We're trying to figure out with the FDA what is the endpoint so we can get this. Now it's in phase 3. We're getting there close, but we're not quite there yet. And eventually this can be used for anything. If you think about it, how many proteins would you like to get rid of? Any bad protein you can identify. This technique, if you can identify the right segment of siRNA, will knock it down. So here's an example in alpha-1. There's some hemophilia studies that are using this technique to knock down antithrombin so that thrombin levels remain a little bit higher. Very potent and very powerful.